Less is more. You want to be very judicious with volume. Remember that the patient can and should be coming back for follow-up a few weeks later. This is how we all learn, from seeing our results, and at that point we can inject more. So it's always better to undercorrect, to inject less. There's one product available which is a very different kind of product. It's not chemically it's not chemically cross-linked, it's thermally coupled. That one, you can inject it in lumps and it will spread to fill the whole compartment. But as a general rule, the lips are unforgiving. They're anatomically sensitive, and we must allow the patient to leave the clinic with a symmetrical result in order to expect a good result ultimately.
Excuse me. I always tell to my patients that when they want a volume V, I put the first session, the half of volume V, and I tell them, while swelling, you will have V. If you like V, we'll put the second half in a couple of days. If you don't like, if your husband don't like, if your mother, if your friends don't like, it will be okay. So I usually do this in 2 steps, in 2 sessions.
But you keep it, tu laisses.
Yeah, it depends. It depends. Si elle veut faire l'essai en
But do you have any recommendation or advice for you injecting your first lip? You know, what would you say for somebody who is injecting their first lip?
The first lip I injected, that was a long time ago, and that's why I stopped injecting fillers, saying this is not for me, and I referred all my patients for almost a decade to the dermatologist. I injected lips, and she came, and I remember I opened the waiting room, and I thought, how are you? And she told me, look at my face. I looked, yeah, there was almost no difference. But she started shouting, and I felt I am not in control of this technique, so I'm going to drop it. And I dropped it until I worked for 10 years with fat grafting, and we have 2 results to show you later with microfat grafting. And once I understood, once other products came, and once I understood something very important, sometimes there is a slight depression in the lip, let's say mostly on the upper lip, and you go on that depression, you start injecting, and it simply doesn't come. The product starts going left and right, but that depression doesn't come. You can inject 1 liter, it won't come. Why? Because there are fibers inside. I can take rid of those fibers while I'm doing fat grafting because I'm using a needle and I'm destroying I can do it with filler, but the patient will be extremely swollen and she wouldn't understand. So we have to understand that there are some areas you're injecting here and the product is going elsewhere to the area of least resistance. So don't keep on injecting because the only thing that you're going to succeed doing is lowering the areas that you don't want to lower. This is something for me, it took me time to understand it, but yeah.
Yeah, I remember just a thing. We didn't speak about some wrinkles, sometimes very deep near the lateral commissure, and it corresponds to the pillow wrinkles. When we sleep, some people do like this, and they have a very sometimes very huge wrinkle here and here, and it's we can correct this with fillers.
Okay, one more question. In relation to the great insights today about inversion of the lip and eversion of the lip, and this great tip you shared, some of you shared, with the superficial fibers of orbicularis ori at the mammalian border, that is one way of achieving this rejuvenating E version of the lip. There are some kind of experts in some meetings talk about pulling the lip and injecting behind and all these kind of different ways to rotate or unrotate. How would you say the things that in your hands worked in relation of everting the lip beyond the physiological, rational, way of paralysis?
Okay. It took me also time to understand that the result I showed you earlier, I could not get it on each and every patient. We have to understand if the orbicularis muscle is, let's say, 15 millimeters high, and if I am injecting only the distal, the caudal fibers, it took me also time to understand that each fiber, each individual has their fibers contracting in a different manner. So it happens that I have patients and I have no guarantee at the beginning to say, you will get a perfect eversion. I have patients I injected, I didn't bring I don't have the video, unfortunately, I didn't take the video, but doing exactly the same doses, exactly the same spots, she was over-contracting the middle tubercle and she developed 2 depressions on the side. Why? I don't know. And it's not only one patient. So I don't want you to go back and do that and say, well, we saw Fed in London saying this and I did it and it doesn't work. It's like for anything. I mean, antibiotics depends, the reaction, it depends on the body. Painkillers, etc., etc. So what I am sharing with you is what gives me, let's say, good results in 80% of the cases, but there is still at least 20% of darkness in my work.
So what about the eversion?
In the world.
In your hands?
Fahad.
What about eversion?
Yeah.
You kind of like only the things that you shared there. Do you pull the lip? Do you do anything? No. Just
Make it simple. When you can make it simple, make it simple.
No.
Fahad has said something extremely important here, which is the value of individualized assessment and treatment based on that. It's along the lines of what I said as well, that the answer to your question, Ali, is that we must look for the primary cause of what we're seeking to treat. So if the primary cause is muscular, then the answer is toxin. If the primary cause is volume loss, then the answer is filler. Now, I'm going to just throw out a figure and say in at least 2/3 of cases or 3/4 of cases in this region, the problem is volume. Some of it is bony loss, some of it is loss of soft tissue. So to me, if I see an unusual pattern of muscular contraction, the first thing I'm going to do is to volumize and then see how that rebalances the muscles in a few weeks' time and then proceed to toxin as appropriate.
Thank you very much. I mean, that really is a very important message. So if I may summarize it, is that no matter how many times you kiss a frog, you cannot make it a princess or a prince. So there is a genetic inherent, kind of architecture of the lips, and if the diagnosis of what's the volume, what is the muscle contracture is what what is going to bring us the best optimum individual results.
One thing that can help also is to ask patients to bring in a photo of themselves when they were younger. We saw some lovely photos from our presenters of patients in their youth compared to how they had aged, and this can be very informative to give us an idea of what that congenital baseline was.
I think Vanya's presentation shows how these 3 levels of classification, maybe you can go around that, from 3 to 1 in relation of volume restoration, and beyond that there is like an inherent architecture of the lips. Vanya, you want to comment on any of that in relation to your review of the literature? Did you find any magical formula?
No, I haven't, but I thought that the paper that I presented is probably the best one because it's very simple and reproducible. I had given a list the classification systems and the validated scales to Dr. Bensleyman, and then he came back to me, I think I said about 10 papers, and then he came back to me with 2 pictures, and he said, Vanya, I just can't find these 2 pictures on the 85 pictures that you sent me. And these are pictures that we see every single day in our clinics. So that proves that, you know, that classification system showing not just lip fullness or lip volume, but show the combined effects of aging and other factors as well. I think it would help us on everyday clinic.